Okay, I see people coming in. Maybe we wait another 20 seconds. Okay, perfect. Let's start. Hello, everybody. Good afternoon, good morning, or good evening, depending on the place where you're on the globe. Welcome to the IPNA webinar of today, which will be presented by Professor Lars Pape. My name is Helena Levchenko. I'm a pediatric nephrologist in Leuven, Belgium. In February, I will move to Amsterdam, the Netherlands, and I'm very happy to present you our speaker, who is a very known speaker, Professor Pape. He is a pediatric nephrologist with a full professorship in pediatric nephrology. He is the director of the University Children's Hospital in Essen, as well as head of their center of their Essen Center for Pediatric Nephrology. His main research focuses in the development and establishment of biomarkers in pediatric nephrology, as well as health services research, mainly in transitional medicine and improvement of care after kidney transplantation. So Lars is also president-elect of the International Pediatric Transplantation Society and the director of studies of the German Pediatric Nephrology Association. So Lars is also an editor-in-chief of Transitional Medicine, so he has a lot of things to do, I would say, and so I'm very happy that he could join us today to present the topic. Lars, I'm going to share your slides in the meantime to present us the topic of recurrence of FSGS after kidney transplantation. Some technical remarks. So this webinar will be recorded and you will find it on the IPNA website. So this is one thing. The other thing is that while listening, you can ask questions during the presentation, but please don't use the chat box, use the question box, and we will try to answer all your questions at the end of the webinar. So Lars, good luck. The floor is yours, and everybody enjoy the webinar.
Sorry. Hi, Elena. Thank you for the very kind introduction, and I'll try the best to give you an overview on what to do, or probably what not to do, in patients with recurrence of FSGS and or steroid-resistant nephrotic syndrome after kidney transplantation. And why do we speak about that subject? And this is NAPTEX data showing that recurrence of original disease is with 7 to 10% really an important cause of graft failure after pediatric kidney transplantation. And we have several recurrent diseases. Today we'll speak about FSGS. But just to set the picture, we have patients with oxalosis who have not been treated before transplantation with oxalosis recurrence in the graft. We have AHUS recurrence in the graft, primarily in regions where no eculizumab is available or from the pre-C5 inhibitor area. We have 33 GNs, and these are diseases really with high risk of graft loss after recurrent diseases. And we also have other recurrent diseases like membranous GN, IgA nephropathy, IgA vasculopathy, GN with other vasculitis, lupus GN that might recur, that recur more slowly than the other diseases, and that are mainly a problem of adolescents and then of adults, and not of many young children. And if we look in an overview on recurrence rates and risks of graft loss, this is quite different between all these diseases. But if you look in the middle for FSGS, you can see that according to the registry, we have a recurrence rate from 6.3 to 31%, comparing France to major data. and we have graft failure rate of about 50 to 65% in these registries. So FSGS recurrence is really frequent in FSGS patients and frequently leads to graft loss. Concerning AHUS, as you know, and primary hyperoxaluria, we have medications that can treat the disease now before transplantation, so that we get less and less patients with these diseases into kidney transplantation, which is lumasiran for primary hyperoxaluria, and which is eculizumab, ravulizumab, and several new complement blocking components that are just developed, so that despite having less patients, we also have, especially in AHUS, a treatment after transplantation, which can in most cases just stop the recurrence of disease. So we are really left with FSGS as our main recurring disease and our main problem. And this is a slide that Catherine Schwambley of Charleston has provided me, and I think it's quite nice just taking into account that why I, which means Catherine, but also me, and maybe most of you, hate steroid-resistant nephrotic syndrome. We have a lack of diagnostic tools that can be used to guide treatment. We have no real good biomarkers. We have a cure that is sometimes maybe even worse than disease, meaning that many patients really have to do severe immunosuppression. We have to use extracorporeal methods, and we have a high burden of our therapy, which in some cases is even worse than the disease itself. We have these high recurrent rates. We have a lot of years of descriptive disease. We have very little insight into the pathophysiology and into clear endpoint for podocyte injury. And we have a lot of heterogeneity concerning these points of probably more than 1,000 mechanisms of podocyte injury. So despite the important clinical problem with this disease, we still don't know enough how to diagnose and how to treat. Before I come to the clinical practice recommendations that we have discussed and finalized in the European Society of Pediatric Nephrology, and together with a certain working group, I'll just start with some literature and some pre-transplant questions, because the recidive of FSGS is not only a question of peri and post-transplant time, but also of pre-transplantation. So we have to think of, can or should we offer living donation in these patients? Shall we do preemptive transplantation, or shall we just transplant after dialysis? Shall we do any kind of preemptive treatment before transplantation, for example, with plasmapheresis, with immunoabsorption, or with rituximab, or anything else? And are there any special immunosuppressive protocols we have to think about? Speaking about living donation, first point is that we, as in all patients, don't have to forget the living donor, and we have to take into account that there is a significant number of proteinuria patients, of diabetes and development of some kind of hypertension in some of the living donors. And if chances of successful living donations, and I'll show that later on, are a little bit worse than in non-FSGS patients, also these donor factors become a little bit more important than in non-FSGS transplantation. So we really have to speak about these donor factors to the donors before doing a decision. Then we have to look on survival probability. And this is just one quite actual study showing here that in living donation, that survival is worse in FSGS patients as compared to non-FSGS patients. And in other studies, the difference, they're a little bit older, the difference is even larger than in this actual data. We have asked the centers in the European Society of Pediatric Nephrology, what do you do for your FSGS patients? Do you do preemptive transplantation? As you can see, there is a substantial number, but it's not all. Some do living related transplantation, some deceased and living transplantation, and some didn't answer that properly. So there's a wide variety what kind of transplantation to do, and obviously there is no real evidence what is right and wrong, and there seems to be no good guidance for the European centers how to go on with these patients and kidney transplantation. And obviously there seem to be quite center specific pathways how to do these decisions. Then we have asking the ESPN, how about your recurrence rate? And there's again a very heterogenic picture, quite astonishing. There's countries like Netherlands and Macedonia saying we have 100% of recurrence, and Greece and Bulgaria have no recurrence of FSGS. So probably that's also a question of the quality of this survey. But at least we can say recurrence rates don't seem to be similar in all countries. Then what is about remission if we have FSGS recurrence? And you can see a third of the center says we have more than 50% where we are receiving remission. Another third says no, it's only 10 to 50%. Then there are 9 centers who says we have in less than 10% of our patients complete remission if we have a recidive. So that might be based on differences in the treatment of remission, but maybe there are also regional differences in the immunological course of FSGS. So also here a wide variety in patients. Now comparing living donation and deceased donation in this older but quite large study, you can see that the advantage we have in living donation in non-FSGS patients with a large difference in 6-year survival is no more there for patients with FSGS after transplantation. We see a tendency for better graft survival for living donation, but there's no statistical difference. And this is just another study, and there are many more where you can just see the same. On the left side, you see living donor transplantation with FSGS, other GN, and non-GN. On the right side, you see deceased donor, and also this study, which is more recent than the other one, shows that this advantage of living donation we primarily have for kidney transplant or pediatric kidney transplant recipients is not that large for patients with FSGS. So living donation cannot be decided on because of survival benefit in FSGS patients. Then we have also looked in our European Certain network, and this is not final data, but some intermittent data which Antonia Bautz provided to me, and we have 25% recurrence in those patients with no graft loss in those with complete remissions, but 3 graft loss in those without remission, and also 1 graft loss in the 4 living donation patients. And we've seen that the parenteral distress was much higher in those patients who received living donation when there was recurrence. So the primary conclusion from Antonia on her data of this study is that non-genetic FSGS with recurrence has a high risk of graft loss when no remission is achieved, and there was no significant difference in recurrence between living and deceased donation. Another question often posed before planning kidney transplantation FSGS patients is, shall a native nephrectomy be performed? There are several studies on that. In the interest of time, I just present here one, but the other studies have more or less the same results, despite the fact that there are some case reports, case report series that show a little advantage. In this study, the recurrence of FSGS is even higher in the patients who received a native donor, a native nephrectomy before transplantation. At least one can say that there's no advantage of a native nephrectomy on the incidence of recurrence of FSGS after transplantation. So, is there any prophylactic treatment we can do to prevent recurrences, and how can we treat recurrences? And we have quite an arsenal of possible medications and extracorporeal methods we can use, like CD20 inhibitors, as rituximab or ofatumumab. We might use plasmapheresis, lipidapheresis, immunoabsorption. Some time ago, abatacept was an option. High-dose cyclosporin therapy was tested, and there are even some more agents that have been studied. There are a lot of studies on rituximab and plasmapheresis with a question whether they could work as a prophylactic therapy, i.e. giving rituximab at time of transplantation, or performing plasmapheresis directly after transplantation. Again, in the interest of time, I won't show you single studies, but just this review that has summarized most of the important studies on this subject. And here you can see on this slide that the treatment with a prophylactic treatment with rituximab, more or less in all studies, and then an overall effect did not lead to any advantage. Rates of recurrence of FSGS were as high in patients who received rituximab as in those preemptively as in those patients who were not treated with rituximab. And more or less the same is true for plasmapheresis. There are some studies with a small number of patients that showed an advantage of prophylactic treatment with plasmapheresis in FSGS. But when you compare all those studies and then summarize the overall impact of these studies, you can not see an advantage of standard plasmapheresis treatment as a prophylaxis of FSGS recidive. So the conclusion of this review was that in unselected patients with FSGS, preemptive rituximab with or without plasmapheresis or plasmapheresis alone was not associated with a lower risk of FSGS recurrence after kidney transplantation. So this is a question that is quite clear to answer. How about retransplantation in patients with recurrence of FSGS in their first graft? You can see that the rate of recurrence in the second transplant is higher than in the first transplantation, but still there is a significant number who had recurrence in the first transplantation and who had no recurrence in the second transplant. So in a very individualized decision process, retransplantation can be a viable option in those patients who had recurrence in their first graft. Now we then switch to treatment of recurrence. First is plasmapheresis, and there are a lot of studies, cumulative case reports showing that plasmapheresis is effective in treating recidivation of FSGS after transplantation. I just chose this study here as a slide because, interestingly, this center was not a high number of patients, had 100% success using plasmapheresis. I think we all know that that is not true for larger populations, and that in some patients, or if you tried to cumulate the published evidence, that in the majority of patients you can achieve a partial or a complete remission in many patients with FSGS recidive, but we also know that this is not true for all patients, and that some of these patients stay plasmapheresis dependent. So in some patients you just do some plasmapheresis and you have remission, and remission stays to be remission. In other patients, if you stop plasmapheresis, the recidive might reoccur, and you have to again apply plasmapheresis or even do prophylactic plasmapheresis for a long time. But plasmapheresis is an effective treatment, but not for all patients. Unfortunately, we do not know before, because we don't have any adequate biomarkers, which patients are those where plasmapheresis is effective. Then we have LDL apheresis. This is something primarily done in the United States, and that is why, again, Catherine Tromley was so nice to give me some slides. And LDL apheresis is probably not the first method we would think about as an extracorporeal treatment of recurrence of FSGS. But if you think about the effects of LDL apheresis, we have a direct effect on lipid adsorption, and in FSGS we have a big imbalance of different types of lipids in the body, just because of that the patients are nephrotic. And with LDL apheresis we can reduce macrophage stimulation, we can ameliorate macrophage dysfunction, and we can reduce inflammatory cytokines. We can then positive vasodilatory and anticoagulant effect by absorption of various pathogenic factors by dextrins, sulfate, like reducing phenylbutyrate and coagulatory factors, increasing VEGF and aerobradykinin production, and a decrease in thromboxane A2 and absorption of a vascular permeability factor, and we might be able to enhance the immunosuppressive response by corticosteroids or of cyclosporin A of MDMA. So there are some mechanisms that probably could help. Sorry. So there have been several smaller studies and several cumulative case reports on LDL apheresis on FSGS. And this is just one study where 2 to 3 sessions of LDL apheresis were performed in the first 3 weeks after a recidive, and then a continuous therapy was done with 1 session per week. And there have been several other protocols, but just in this study you can see that those patients who received LDL apheresis were quite stable with their kidney function even after completion of LDL apheresis. But on the other hand, you can also see that there was a wide variability of 4 to 25 months of performance of LDL apheresis, which was very individualized to the patient's need. And what is quite interesting, that the FDA has approved lipid apheresis with the Lipsova LA15 system for the treatment for FSGS and also FSGS recidives after kidney transplantation. So this is really an option used more and more, at least in the United States. In Europe, we have used immunoabsorption for recurrent FSGS in many centers. This is a method that is not available from what I know in most of the US centers. And immunoabsorption, obviously there's not that much literature as in plasmapheresis, but those studies that have been published with immunoabsorption also show that in many patients, immunoabsorption can lead to complete remission in case of a recidive of FSGS. But again, there is a number of patients who require continuous or long-term immunoabsorptions to keep the patients in remission. And if you stop immunoabsorption in some of these patients, the recidive will occur again. So at least we have 3 different extracorporeal methods we can use. How about rituximab in treatment of a recidive? This is, I think, a nice review by Richard Grenda stating the title that rituximab is not a magic drug in post-transplant recurrence of nephrotic syndrome. And this is just his data showing that in some patients, an additional treatment with rituximab led to complete remission after recidive in transplantation. We know it does not work if you do it as a prophylaxis, and there are also patients who do not profit from rituximab, but I guess most of you use rituximab in addition to plasmapheresis, immunoabsorption, lipid-apheresis, whatever you do in your patients with a recidive of FSGS. But again, as with all the other methods, we know that rituximab works in some of the patients, but not in all of the patients. And actually, we do not have good biomarkers or other ways to detect those patients who will profit and those patients who won't profit from rituximab. Immunosuppressive therapy, there are no really good competing studies of different immunosuppressive regimens in FSGS. There have been older studies that show that especially intravenous cyclosporin therapy in recurrent nephrotic syndrome after renal transplantation works in many patients. There are also some studies that show that high doses of oral cyclosporin work. For tacrolimus, not such studies really exist, which will not exclude that tacrolimus and high dose will also work as good as cyclosporin. We don't really know about that, but from the most evidence we have is in fact on intravenous cyclosporin. And there are the first studies of afatunumab and also of obinutuzumab as other anti-CD20 antibodies in FSGS. And we see the same as we see with rituximab. Some patients are in remission, some in partial remission, some in no remission. So there, with our actual knowledge, there seem to be no real differences between the CD20 antibodies, and the 2 new ones do not seem to be an absolute game changer as compared to rituximab. I've spoken several times about the biomarkers in this actual review. You can see that at least some biomarkers may have some clinical utility as serum super, as urine super, anti-CD40 autoantibodies, A1 antibodies, CLC1, and anti-ATR1 antibodies. There have been some retrospective studies that have shown some predictive value, but in fact there are no studies who've really steered interventions by these biomarkers. So to be honest, there are some hints on these biomarkers, but we have no real evidence at the moment that we can really use them for predicting what will happen with our patients, and absolutely not for steering our therapy in our patients. Because of all these problems that we have, because of the heterogeneous literature, and because of all these differences, we've seen the European centers, what they did before transplantation, how they decided to do transplantation, what they did in a case of recidive. We set in our ESPN working group transplantation together with the certain registry group that we would like to at least do some guidelines, and we ended up to do some clinical practice recommendations for recurrence of FSGS in SRNS. And for these guidelines that have been published 2020 in pediatric transplantation, we posed 2 PICO questions, one on native donor nephrectomy and one on immunosuppression plus minus plasmapheresis. And then we did a complete literature research and had a lot of publications and a lot to include. And I showed you some of the most important of the papers we used for the review in the data before. And yeah, here you can see also the search strategy in Biomed Central. And but we only found and we certified the literature due to the Oxford classification from RCT to mechanism-based reasoning. Unfortunately, there were not that many studies that were really of high quality. Obviously, we didn't expect that before, but and there were larger retrospective reports, case reports, and some prospective studies, and we used all of them together, graded them, and then composed our guidelines. I've not the time to demonstrate that in detail, but I'll give you the educated statements on these 2 PICO questions. And we came to the conclusion that the rationale for living donation in children with FSGS should be based on factors other than better outcomes typically associated with living donation transplantation, because as I've showed you before, living donation does not improve the outcome. But an argument pro living donation might be long waiting time for cadaveric or deceased donor transplantation. But we really have to do a good informed consent to the parents and really have to explain them all the risks we have of a recidive after transplantation of a living donation of a graft. Second, native kidney nephrectomy prior to kidney transplantation as a preventive measure cannot be recommended, however, may decrease the risk of early graft thrombosis and help to distinguish recurrence from persistent native proteinuria. I've showed you some of the data concerning that recommendation. Number 3, a retransplantation in case of a previous renal allograft lost to FSGS recurrence may be associated with worse outcome, but it's possible. A young age, and I didn't show you that data, at disease onset and white race may be associated with a higher risk of recurrence. Pediatric patients with native kidney may change histology in initial biopsy and secondary, and as shown, increased risk for disease recurrence following kidney transplantation. And concerning PICO statement number 2, early treatment of plasmapheresis may be effective in treatment, probably not in prevention of post-transplant recurrence of FSGS. In addition of the monoclonal anti-CD20 depleting antibody rituximab to plasmapheresis may be considered as treatment strategy. High-dose CSA may be considered as a treatment strategy, and RAAS blockade may be considered in post-transplant recurrence of FSGS and sRNS. We couldn't do any really clear statements, for example, on immunoabsorption or on lipid apheresis, as there was not enough adequate literature with an adequate level of evidence when we made these guidelines. We then tried to develop a kind of scheme how to diagnose and how to handle FSGS recurrence, and this is just a suggestion in a kind of clinical practice guideline. This is something primarily Lutz Weber has developed together with our group, and we've said, okay, in children with primary FSGS or sRNS, before transplantation, we have to perform a genetic work up to be sure whether we have genetic or non-genetic FSGS, and in kind of living donation in genetic forms, we also should do a genetic workup and counseling of the donor candidate, and we shall assess proteinuria prior to transplantation. And then we should do a risk assessment. We have low risk for patients with a previous history of recurrence with no previous history of recurrence in a renal transplant, with a non-genetic form, with a younger age of onset, with and a higher risk with those patients with a younger age of onset, with complicated pre-transplant course or white race. And then we can do the transplantation after we've assessed that kind of risk. We should then perform a close monitoring of proteinuria. And this is just a compromise of all the different ideas we had: daily for 2 weeks, twice weekly for 4 weeks, weekly for 2 months, every second week for 3 months, then monthly for 6 months, and every 3 months thereafter. We should, in case of proteinuria after transplantation, consider other causes of proteinuria like ischemia, reperfusion injury, proteinuria of native kidneys, rejection, drugs, hypertension, infections, IFTA. And if we have no clear other explanation, we should consider a transplant biopsy, especially in the case of low serum albumin. In some patients, I think it's quite clear that we have definitely an FSGS recidue, then we probably don't need a transplant biopsy. Then we can distinguish between recurrence and non-recurrence, and recurrence. Concerning the actual evidence, we should do early plasmapheresis, or if we are used to that, we can also use immunoabsorption and may probably combine that with rituximab after plasmapheresis immunoabsorption therapy, and should use an ARPA-ACE inhibitor. And if we have an adequate response to plasmapheresis or immunoabsorption, then we have to decide about using high-dose CSA, rituximab if we haven't given it automatically with our extracorporeal method, maybe a switch from plasmapheresis to immunoabsorption or vice versa, because we've seen patients that respond to PE but not to EA, or vice versa. We can think with the US data on LDL apheresis, and this might be combined with steroid pulse therapy because that was done in several of those studies. And we might also think about other CD20 antibodies. So how do we go on with that, and what are the future directions? So I think, and this is a sentence also borrowed from Catherine Twombly, all children are different, and we have so different courses of FSGS before and after transplantation that we really have to try, with the knowledge we have, to tailor the therapy to the needs of the patient. We have to use patient reported outcome measures for that, and we have to, as far as we can, really to individualize the therapy and not follow the same scheme. For patients, we really have to work on more collaborative science and FSGS concerning mechanisms, biomarkers, and clinical trials. And we really have to be honest with ourselves and honest with the patients and their families, and have to acknowledge the knowledge gaps that are there, and have to educate ourselves and our patients about what we know, but also about what we don't know, and what risks we are right to accept concerning our therapy, and concerning the disease and the disease recurrence itself. So thank you for listening to this presentation. I like to advertise the Saving the Kidney Health and all when disaster strikes online virtual format for 4.5 hours on 8th of February as a global health online symposium combined by IPNA and ASPN. And here's the registration link. And I also like to advertise the 12th Congress of the International Pediatric Transplant Association. We all together have in the end of March in Austin, in Texas. And we have a very nice program with fantastic abstracts, and who is not registered is happy to register now. And I think many in the audience are obviously interested in pediatric kidney transplantation. So we, from the IPNA Executive Committee, would be very happy to see you in Austin. So thanks again very much for listening, and I'll close with 2 photographs of the new Children's Hospital that is just being built in Essen, and we hope that in 2024 we'll then be able to move in this nice building. And now I'm happy to answer any questions as far as I can.
Thank you so much, Lars, for this wonderful presentation, very practical. And congratulations also with the new hospital, and also good to hear that congresses are starting to be organized, also live congresses where people can move. So I see questions coming, and the first question here on my panel is how to recognize the recurrence of FSGS. And the example is provided of a girl with a history of primary FSGS, currently post-transplanted 3 years from a cadaveric donor, who is presenting with proteinuria in nephrotic range. Is it a recurrence or is it a de novo nephropathy? How can we recognize it?
I mean, that is in fact a difficult question. I mean, if you had FSGS before, I think it's much more probable that you have a recurrence of the FSGS, even a late recurrence, than having a de novo FSGS in your kidney. But obviously, there's no black and white, and it might be difficult to distinguish both forms. On the other hand, that won't, at least in my opinion, really change treatment. And whether you have de novo FSGS or primary FSGS would result more or less in the same chemo you would do with a patient.
Yeah, I agree. So another question is, so in the past it was recommended to wait for several months to retransplant the patient in case of recurrence. So I have an idea how long should we wait prior to consider a recurrent FSGS patient for a retransplant?
So unfortunately, this is something you can see that we have not answered that in the PICO question, because there's really no evidence. The idea of waiting is that your disease gets somehow burnt out after time, and if you transplant, then there would be a lower risk of recidive. But from my knowledge there, and from all that what we looked at literature, there's in fact no real evidence on that. And the problem is, the first answer is, I think there is no time that is valid for all patients, because we have those patients that are immunodependent on, i.e. immunoabsorption for 2 years, and after half a year or whatever, the parents start you to ask whether to retransplant or not. There are patients who have a short recidive and the organ is or you're back to end-stage kidney disease 3 months after transplantation, and you have patients where you have a very slow progressing FSGS in your kidney, where you probably would wait then longer after your kidney got lost. But I think it's a very individual decision. But at least from what I know, there's no real evidence that waiting longer really reduces your risk. What is your opinion, Elena? I've just discussed that.
Well, I think we don't really know. That's how personally I'm very cautious to transplant a patient with ongoing nephrotic syndrome. I think my point was always really to wait until the proteinuria is really going down, because I think when you transplant a patient really with high level of proteinuria, it's very difficult to distinguish between the relapse and the proteinuria from the native kidney and the high risk of thrombosis. So I think, I don't know, what do you think about at what level of proteinuria would you even consider a patient to be retransplanted?
Obviously, you won't. I'm absolutely see this the same as you see, that we won't transplant a patient who has nephrotic proteinuria, because you can't really diagnose a recidive. But that may be patients where native kidney nephrectomy might make sense before transplantation, or if you have a recidive in a patient on dialysis, where you don't see a chance of any remission of FSGS, but you still have a nephrotic proteinuria, this might be one of the few patients where graft nephrectomy might make sense before retransplantation. And if you do a graft nephrectomy, then you might have the possibility of acting earlier with a retransplantation, but I want generally transplant nephrotic patients.
Yes. So we have some other interesting question about the potential of stem cells in this setting. Do you have any idea or some literature on that?
To be honest, no. I've read a little bit on that, and I've seen some abstract, but I'm not very confident in that matter. So I think the future will show, but that's not my specialty, so I can't say much to that.
Yeah, me neither. I just don't know. There is another question about the potential of ACTH in patients who are plasmapheresis and rituximab resistant.
Again, I don't know. I've seen at least case reports that showed a positive effect, but I think that's all I know or that we know.
Yeah, I think it's also very difficult to say because we really have no evidence on that, and it's very difficult to say something based on very little data. Yeah. Okay. So maybe another practical question: if you have a patient with a recurrence of FSGS, and you start with one of these extracorporeal techniques, mostly plasmapheresis, how long would you go? How long would you continue?
I mean, that is depends on the success of the method we have. So obviously, if we have a complete remission after 3, 5, or 6 plasmapheresis, we would do some more, but then stop and wait what will happen, closely monitor proteinuria, and then probably restart if proteinuria is re-increasing. If we have a partial remission, we would continue quite long, trying to achieve a complete remission, or if it stays to be partial, but I can't say that after even some weeks, we would really try to switch between plasmapheresis and immunoabsorption, or vice versa, depending on what we have started, looking whether one method would be better as the other method, or even now use LDL apheresis. The most difficult question is, if we see no change, how many plasmapheresis will we do? I think most of us would do like 6, maybe some more plasmapheresis, but if you don't see any decrease of your proteinuria and increase of your serum albumin, you would probably try to switch to the 2 other methods, use other medications, but not carry on for weeks on plasmapheresis.
Okay, I agree. So there is another question about if you have a recurrent FSGS and you treat those patients with plasmapheresis or other drugs, when is the best timing to add RAS inhibitors in this case?
We would at least give them as early as possible when we have proteinuria, because I don't think that RAS inhibitors do hamper any other treatment. So if we have proteinuria for more than 3 days or whatever, we would in parallel start a RAS inhibitor.
Right. So I think probably, yeah, RAS inhibitors should always be included unless you have contraindications. Yeah, okay.
I mean, even in some years ago, we were thinking about if we should really use a RAS inhibitor even for treatment of hypertension 4 weeks after transplantation. But I think today, and also from the adults, we know that there's no risk of early use of RAS inhibitor after pediatric kidney transplantation.
Good. The questions are still coming, so I think you still need some energy. So the other question is, do you suggest any modification on immunosuppressive therapy when you transplant FSGS patients compared with non-FSGS patients before the sign of recurrence? Would you use different immunosuppressive protocol?
Yeah, I've not said much to that in my presentation, as you have seen, and we had a lot of discussions in the ESPN group if we can give any recommendations on that. There were some people saying, okay, we should treat all of these patients with high-dose oral cyclosporine because we have some data that high-dose oral cyclosporine could be better. Others were very few were saying, why not using intravenous cyclosporin for all from the beginning? But there's no real evidence that intravenous cyclosporin as a kind of preemptive therapy does really reduce the number of recidives. That is why we stated in our guideline that we will use intravenous cyclosporin only in case of a recidive that is resistant to the first course of plasmapheresis. And then there were obviously a lot of centers saying we always use tacrolimus. We think it's not worse than cyclosporin. We can use high-dose oral tacrolimus, and we won't just switch to cyclosporin only for our FSGS patients. But again, there's no good, even retrospective data evidence in comparing cyclosporin to tacrolimus in these patients. All that we can say is from expert opinion and experiences of centers that probably there is no difference in using standard protocols with CSA and MMF or tacrolimus and MMF. You won't probably use primary immunosuppression with an mTOR inhibitor, as that is not recommended with proteinuria, and as there is no experience with mTOR inhibitors in inhibiting FSGS recurrence. But in our opinion, and in this expert group, we said do a standard immunosuppression with TAC MMF or cyclosporin MMF and aim for higher CNI levels. And obviously, and we won't do steroid-free immunosuppression, but even that is not really of evidence.
Okay, yeah. We also use the standard immunosuppressive protocol for those kids and see how it goes. The colleague who was asking about the stem cells was referring to the New England publication on combined stem cells and kidney transplantation in Schimke. But I think there is no data in other diseases as far as I know.
Yeah, and this, with Schimke, this is quite even one patient who asked in our center if this patient could receive combined stem cell and transplantation. We in fact sent them for a second opinion to Stanford to whether they would do it or not. So this is very interesting, but it's, you know, it's quite heroic, and it's not of low risk to do that procedure if you read that paper. So even for Schimke patients, I think after this publication, it's valid to take some time to really think about doing that. But I don't know any again about FSGS and combined stem cell transplantation, whether that could work or not.
Okay, I'm just checking the question bar. I think we went through all questions. So maybe Lars, because there are a lot of discussions, so maybe you just can share your personal opinion or the protocol in your center when you have a patient with recurrence of proteinuria having FSGS as a primary diagnosis. What will you do in Essen?
What I've just shown you, because this is more or less a consensus we reached in Germany and for many European centers. So we would consider kidney biopsy as no. Are we sure this is a recidive or maybe something else? We would very early start with plasmapheresis, as that is the method where we have most data. We would at least increase our oral CNI, for example, if we've treated the patient with tacrolimus, really to have levels around 15. If we have levels around 10, we would start an ACE inhibitor if we have not done so. We would always give rituximab, probably after the third plasmapheresis session, and then wait, I don't know, 48 hours or so for the next. Then do close monitoring of CD20 cells, because we have the problem that maybe part of the rituximab we've administered will just leave the patients via the urine. So maybe more doses of rituximab are needed to really achieve a complete CD20 depletion. I think it depends on the patient, but if we don't see after the third plasmapheresis any reduction of proteinuria, we would switch to immunoabsorption in that patient, hoping that this would work better. Then we would really individualize what we do. Next step could then be to use IV cyclosporin A, but it really also depends on age, on the history of the patient, and on many other aspects how to perform. But if we can call it so, standard residue of an FSGS, this would be a thing what I think we would do in all more or less more German centers and what we would do in Essen.
Wonderful. And in the meantime, I think I have the very last question from the audience. To which extent the kidney biopsy helps you in those patients? Because frequently you will not see their FSGS lesions at the early stages of recurrence. So what is the reason?
It mainly helps you to exclude other diagnoses. But if you have a severe nephrotic proteinuria in FSGS patient, you don't do, or we won't do, a kidney biopsy. But if you have slowly starting proteinuria, where you think about, may this become a full FSGS recidived, then the kidney biopsy on the first hand helps to exclude other diagnoses, and you often see, at least in the electron microscopy, what is that? Changes in podocytes, for instance, leading in the direction that you won't see FSGS, but you will see early changes in podocytes effacement and so on in the electron microscopy that might help you to decide on starting FSGS therapy when you see no other pathology.
Okay, wonderful. Thank you so much, Lars. I think we had a wonderful webinar. We learned a lot about how to approach recurrence of FSGS after kidney transplantation, though there are a lot of questions, so there is a lot of space to research in that direction, maybe trying to discover the biomarkers, your field of interest maybe. Okay, thanks a lot for attending the webinar, and see you on our next clinical practice webinar in the future, and goodbye.
Yeah, and thank you for the great moderation.
Bye.
Bye.